Hey everybody, this is Erica Mello, and welcome to episode number 200 and oh gosh, 211. And for those of you who are watching this on YouTube, you can see my background. That's actually a real background. I'm in New York City. For those of you who listen to the podcast a long time, and I'm actually in the office recording this. And this is sort of the windows and sort of the background, or all of those buildings behind me. This episode is a shorty. I always say it's a shorty, and we always try to keep them short because I know we have longer episodes on the off week. So this is about the knee, and this is a two-parter. I recorded part of this, as you'll see, because I won't be in my office. I recorded a piece a while ago on how to assess the knee differently when your patient actually has knee pain. Sometimes it's really difficult to assess a squat, a lunge, things like that when the patient has knee pain. It's really provocative, and you need them to do a movement in your office at least a few times, more than a few in my case. That's not going to flare them up. And if someone does have issues with with their knee, with sort of loaded squats and lunges, the back end of this episode will talk about what I do to get around that. But I wanted to embellish a little bit more on issues with patients who have symptomatic knees. More often than not, it is not their knee that is their driver, and sometimes it is. So I want to just sort of talk about how I assess that a little bit more. Not getting into too much detail. It's best served when I'm actually doing it on a patient. But you'll get an idea of maybe other options in your practice for different ways to look at the knee and what to look for. We hope you enjoy the episode, and for those of you who are new to our podcast, thank you for joining us. And for those of you who have been here for a long time, thank you for being such loyal listeners. We truly appreciate it. Our website is still toughtotreat.com. We've got over 200 episodes now. So for those of you who, going into the summer, you want a little refresh on some episodes, and you want to see if we've done something on pelvic girdle pain or low back pain or shoulder pain, just type in the search bar on our website, toughtotreat.com, and all the episodes will come up with those keywords in there. And we still would really appreciate it if you could leave us a review on wherever you listen to us. Reviews really help us in the algorithm, and if you found value with what we talk about, Susan and I would really appreciate it. So I'm going to go on to the episode. Hey everybody, welcome to episode number 211, and this is Erica Mello, and this is a shorty week for us, as I mentioned in the intro, and it's all about the knee. The second part of this episode, if you're going to be watching on YouTube, you'll see that I am not in my office here. I am at home. So I recorded the back end of this episode a while ago, but I wanted to update it because I talked about, you'll hear about assessing the knee a little bit differently in terms of when you can't have the patient squat at the same times, right? A lot of people with knee pain can't squat, but can't go downstairs, right? So, but I wanted just to throw this out to you. For those of you who see chronic knee pain, I don't see a ton of acute knee pain unless it's somebody that's coming in to see me who's already on my schedule, like who's been a patient before, and they just want to come back. Okay, so it's really more of the sort of the chronic knee issues that I have, and I will tell you just from my own experience, I hyperextended my knee at the beginning of the pandemic. I was going to see a patient in his house, and I literally heard a pop in the back of the knee. I was like, oh no. I never had knee issues, and I was not about to let it happen again. And so I moved on. And it didn't bother me. And over time, it got a bit better, and it would bother me up and down stairs occasionally, but not as much. But recently, I started walking a lot more up hills, and it was bothering me. And so, for those of you who don't know my history, I've torn my hamstring twice on that same side, my right side, and so. Typical physio fashion, didn't get it treated as much as I should, yada, 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 right? We all know, we should get ourselves treated more. And That is actually going to be one of my goals for this year. So scar tissue builds up, dominant patterning builds up. It's very common even with our own patients. If what's typical with ankle sprains? Who sees a physio after an ankle sprain? Not many people. It usually gets better, right? But over time, especially people who are hypermobile, you will compensate around that because there are movement deficits after ankle sprain. So with my story, that the hamstring tear, and which was 2015, it was a while ago, and with my hyperextension of my knee during the pandemic, I was okay until I wasn't. And this is what I tell patients. I said we can adapt over time. It's how we live our life. It's how we live our life, right? And so what I think, what I think is really more important is how we can explain to our patients, yes, your knee hurts now and you've had these issues years ago, but we build up compensations and adaptations over many years. We're really good at it as humans. But then something challenges our system and we go back to our dominant strategy. Okay. And that's sort of generally what I tell people. So in terms of assessing a knee, in the second part of this audio video, I talk a little bit more about the body twist, but I want you to think about, it's not just the tibiofemoral joint, it's really more, tib fem joint, patellofemoral joint, and superior tib fib joint. In my experience, the superior tib fib joint is not the main issue, unless there's direct trauma there, okay, directed trauma into that superior tib fib joint. This is the reason why I wanted to talk about this today, is because I don't know if all of you use mirrors in your practice, if you have a mirror in the room you're in, or you have access to a mirror. So it's very important for you to train your vision for any joint, to be honest, but especially with the knee as well. And so if you don't have a mirror, just order one, freestanding one, $30 on Amazon. Train your vision. We did that during the pandemic, right? We trained our vision a lot, right? And so because we weren't seeing patients a lot at the beginning in person. And so, you want to be able to look at a person squat. Let's say they have knee pain and squatting is okay for them, and they squat down, and you see some non-optimal patterning. They come back up into knee extension. Their tibia is laterally translated. You can see their femurs internally rotated. Palpate the medial and lateral joint line. Close your eyes and have them squat and see what that pattern feels like. Take your hands off, have them do it again. Look at your visual, have them squat, and then repalpate. Train your vision and train your hands. Do they match? I would do this with every single joint in the body. Same with the shoulder, the head, the foot. Look in the mirror. Is what you're seeing matching what you're feeling? You will raise your expertise multiple notches if you can train that, because you need your eyes. If you have your hands on somebody and you have nobody around to help you, and you need to do something with your other hand, you need to look in that mirror and see what's happening to the rest of the body. And so there's one thing, and I'm talking about the knee because the knee is easy to see, right? This knee is easy to see in the mirror. And we know as physical therapists what non-optimal patterning looks like in the knee. It's different for everybody, but we can do multiple movements in front of the mirror. Okay, so you want to palpate the medial lateral joint line. Go back to the anatomy book. I know we all did cadaver anatomy at one point in our physio lives. I did it before, actually first thing in PT school. I'd love to do another one, actually. Go back to the anatomy book, see what muscles attach there. I've torn my hamstring twice. My medial hamstring is a significant muscle overactivity and for my knee pain, significant adductor, right? And so you want to be able to correlate your vision with your hands, and medial lateral joint line, go on the medial and lateral femoral condyles, go down to the patella, go down to your superior tib fib, palpate all of those, look in the mirror and train your vision. And I'm not saying that all of those joints in that person's knee are the reason why they have knee pain. It may not even be their knee. A lot of times it's the foot. But this short episode, I just wanted you to get an idea of how you can use the mirrors and you can use your vision to train your knees, oh my Lord, to train your eyes, because there's a lot of times we may not have access to a mirror, right? But we can feel because we've trained our vision, right? It's very typical patterning to have a lot of medial lateral joint line compression, both sides, right? Medial and lateral from overactivity, vastus lateralis, medial hamstring in my case, adductor, those muscles need to get released. But after an assessment has been made, right? And we assume that the knee is the driver, right? It may not be. But what you want to think about with the knee is that, most people have issues when it's loading, walking, standing, squatting. So you want to think about the foot, think about you need to assess the knee in varying degrees of dorsiflexion. Standing in a squat is basically neutral. And then you go down into a squat, you're going to get more dorsiflexion. Look at it in plantar flexion. Do not forget that. We have to push off when we walk. Do not forget assessing the knee in dorsiflexion, plantar flexion, knee extension. It should go through all of those ranges of motion. And you can do it on the table, in a squat, whatever position you want. But I really think that we need to assess this important joint, because it is in the middle of the hip and the foot, in various degrees of knee flexion, knee extension, even hip flexion, hip extension. Because when you're walking, right, let's say it's the right knee, that right leg is behind you, you're pushing off your plantar flexion, knee extension, and hip extension. Those are three joints, right? And your non-optimal patterning may be very much just in that particular part of the gait cycle: plantar flexion, knee extension, hip extension. Or it may be just squatting, which is dorsiflexion, knee flexion, hip flexion, right? So you want to really use your clinical reasoning skills and think about, what point in the range of motion or what point in the activity is this person's non-optimal patterning coming forth, and you're going to use the mirror for that. So I know I could talk, a lot about this, but I just wanted to sort of give you a couple clinical pearls with regards to the varying angles of movement and also just using your vision. Okay, and go back to the anatomy book. Really go back, because you will be able to, if you just palpate the femoral condyles and just train your vision, you're going to be going way more than most therapists do, to be honest. And your patients will be really happy you did that. And so the next part is going to be on the superior tib fib joint and a body twist. You'll see that I'm not in the office here, but it was something I had recorded a while ago. So once again, enjoy the episode. Enjoy the rest of the episode.
Hey everybody, I just wanted to give you just a quick sort of clinical pearl with regards to knees, knee pain. So we've done, I think we've done several podcasts on knee pain over the years. One really early on, a junior golfer I treated, actually, I think that was podcast number 10 maybe. He's actually in my book as well. So, as well as in my course that's coming out soon. And it's important to assess the knee in different ways, because a lot of patients who have knee pain, they can't really squat well. They can't go up and down stairs. And if you start assessing the knee, having them squat multiple times, you're just going to flare them up, right? So, you can certainly do, I'm talking off the table, like you can do all your tests for their knees on the table. But when I see patients who have knee pain, I know the knee can be a primary driver for certain, for certain problems, but I often don't find that to be the case unless it's an acute issue. The knee could definitely be in play, but it may not be the primary issue. So I look at the knee a little bit differently. I will watch the person squat, but if it's very provocative, I will not do that. So I actually I have them stand and do a body twist and just take a look at the knee in rotation, like when your feet are sort of in parallel, and I'll just have them go turn right and turn left. And we all know the motions that should happen in the feet and the knees when they are doing a body twist. And if you're not comfortable assessing the knee in that way, just at least look at it and see if if it's provocative, right? So, I usually get my hand on the tibia, on the femur and the tibia, and I kind of assess rotation and, as well as, medial and lateral joint line. That's a whole nother video, but I do that. I also look at the feet in a body twist. But there are many, many times when you have patients who have knee pain and you cannot get them to squat or get them to squat consistently. Because when I assess patients, I ask them, I say, I'm going to have you squat. I'm going to have you do a movement that you're going to need to repeat consistently. Are you okay with that? If they're not, then you need to find something else, right? So a body twist is a generally sort of low load, a way to sort of look at the knee in the back door if that's the only other option available to you. And you know that the foot is supposed to sort of, quote, pronate, supinate, when they're turning, right? So if you have somebody who has right knee pain, right, and you have them do a body twist to the right, that right foot should get rigid, right? It should supinate a little bit, for simplistic purposes here, right? If they're not, if they cannot develop a rigid lever when they're turning to the right, if they can't sort of, I want to say supinate. If they can't do that and they're complaining of knee pain, well, maybe you can assess the foot as well. That could be in play. It's another way it's very hard to check thoracic rotation in that position because they're rotating at their hips. I also get behind them and I can put my hands on their PSI, on their ASISs, and I'll take a look at hip rotation. So what's going back to the example of rotation right, when you are rotating to the right, obviously that pelvis is going to go into a transverse plane rotation right? And if you feel that femoral head, becoming more, quote unquote, non-optimal going anterior, you feel some medial compression in the hip when they're doing a body twist and they're complaining of knee pain, well, then maybe the hip could be in place. So there's many ways that you can assess the knee if you can't have them do their provocative movement, like a squat, for example. The body twist is a good way to do that, and you could also rule in and rule out other areas. For example, going back to the foot, if the foot is not developing a rigid lever when they're going to the right or supinating, quote unquote, you can facilitate that movement and see if it makes their knee feel better. And if it does, well, then maybe the foot's definitely part of your driver, profile. So I hope that helps, and enjoy.